Hi, everyone. I'd like to welcome you all to the Society of Skeletal Radiology Resident Education Club webinar series. My name is Stacy Smith from here in Boston at Brigham and Women's Hospital, Mass General Brigham at the Harvard Medical School, and I'll be serving as moderator for this session. I wanted to ask all of you to put comments into the chat, but any questions that you have specifically for the speaker should be put in the question and answer section. At this time, it is my pleasure to introduce to you our speaker today. This is Dr. Edward Smitaman. He is a clinical professor at the University of San Diego, California, and he is going to be speaking to you on interesting muscle cases. A little bit about his background. He trained at SUNY Upstate. He did his residency at Yale and then did his fellowship at UC San Diego. He then was an assistant professor at Yale, and then in 2014 went back to the West Coast and has been at UCSD. And we are delighted to hear the presentation today, and I will let you take it away.
Thank you, Dr. Smith. Appreciate it. So today, hopefully you guys, everyone can see my screen and arrow, and thank you for the invite. I was asked to share some interesting cases on muscle, and today we'll be focusing on atraumatic muscle cases. There are a lot of other articles and talks about trauma, but today we'll be focused on atraumatic muscle cases. So as we know, as radiologists and physicians, this encompasses a wide variety of disease, including congenital anomalies, accessory muscles, what have you, inherited myopathies, acquired inflammatory diseases, infectious, ischemic, even neoplastic, and some other conditions leading to muscle atrophy. These disorders share a lot of similar features on MRI, and it can be very challenging for us as radiologists, not only to clinically but also pathologically, to differentiate and correctly diagnose them. So today we're going to use a case-based approach, or I'm going to share a case-based approach, so to try to classify some of these muscle disorders to better assist, obviously, our clinical colleagues, but obviously to help patients. For those that are techies in the crowd, this is my IG, as you young crowd know, and this is obviously a quick response. So I'll leave this up for a second, but I show it later again. But these are some cases that we see here at UCSD. I do a little bit of ED imaging too, but it's mostly just ED cases and MSK cases. I have not, posted in a while. Hopefully I'll get back to this in a bit, but please feel free to check out some of the cases that we see here at UCSD, and I welcome all comments, and if you'd like to share a case too, I welcome that too, always wanting to learn. Thank you. Disclosures, I remain optimistic, okay, but none yet to disclose as of today. So, starting with the bottom left-hand corner image, William Conrad Röntgen, as we know, father of radiology, back in 1895 November, fall of 1895. So conventional radiology and CT, top right corner, 1968, 67-ish, Sir Godfrey Hounsfield. These modalities are effective, okay, in identifying radiopaque foreign bodies, gas, and intramuscular mineralization. However, as we know, studying radiology, they lack sensitivity, right, required to detect the majority of muscle disorders, okay. In the late 1940s, bottom right corner, Carl Theo Dusek invented or used first ultrasound. He was I think a neurologist, but as we know, ultrasound provides high spatial resolution of muscle, but is not as sensitive as we know as to MRI for identifying especially edema and early myopathies, okay? Despite this, right, ultrasound has an important role in identifying muscle variants, distinguishing cysts and solid neoplasms, assessing vascularity, right, and also really helpful for guiding really superficial percutaneous interventions like aspiration and biopsy. So we like to do a lot of our obviously muscle biopsies when we do get them requests under ultrasound. And then top left, moving on to Raymond Damadian and his assistant, and pictured here, Larry Minkoff in the late 70s. Okay, imaging the chest under MRI, and as we know, MRI is going to be the workhorse for muscle imaging. Okay, it displays the structure of muscle very well with its intertwined fat, bright on T1, the fat is that is, and fascia, while T2 and stir imaging is highly sensitive for obviously fluid, edema, and muscle swelling. So we use MRI to investigate these muscle disorders, but imaging, is usually done, small area captured the muscle disorder, but I would highly recommend considering large field of view imaging because sometimes, especially with muscle diseases, you can have bilateral or multiple muscles affected, and that may change the differential of what we're thinking, especially when dealing with inflammatory myopathy. So MRI, this talk is going to be obviously then MR heavy. Muscle disorders, okay, and we looked at the way we look at muscle disorders here out west is we try to group them into four muscle patterns. First pattern, far left hand of image, okay, is the abnormal variant anatomy with normal signal intensity. The second is going to be edema or inflammation. Third is going to be intramuscular masses. And then fourth is just going to be typically chronic, but atrophy and tissue loss. And I credit and I like to give a shout out to some of my co-authors on this. We put out a radiographics paper a few years back, and this is images created by Diane Flores. Great, and she's put out a couple articles in radiographs. I highly recommend you check out some of those. But she really great artist, as you can see here. So starting with the abnormal variant anatomy with normal signal, okay? Variations, as we know in muscles, can be caused by congenital, post-traumatic, fascial weakening, for instance, muscle hernias, or even surgical procedures, muscle flaps, what have you. It can be challenging to recognize by MR imaging unless you have to know anatomy. Once you know normal anatomy, no one can touch you, okay? But basically on your T1 and T2 weighted sequences, it's just going to follow muscle signal. As in this case here of the wrist slash hand, we see this fiduciary marker marking, okay, the extensor digitorum brevis manus muscle. And if you feel the back of your hand right now, typically you should only feel tendons. You shouldn't feel like a soft tissue mass or anything like that. There should be no muscles crossing your metacarpal. So if you have something there, muscle signal, this is one of the common anomalous muscles that can happen at the dorsum of the hand, and something to think about. Accessory muscles are common and most common form of muscle variation, and can be seen in up to, depending on who you read, about 5% of patients. And typically, as in this case here, likes to involve the hands and the foot. So this is EDB manus muscle. And interestingly, I only show you one hand here, but the patient actually, we also imaged the patient's other hand and actually had bilateral extensor digitorum brevis manus muscles. Moving right along, as I mentioned in the feet, or here, as in this case, the ankle, okay, these accessory or anomalous muscles are often asymptomatic, but can manifest clinically as a painless palpable mass. So we don't want to confuse this for a tumor, but again, it's going to follow muscle signal on your T1 and T2 weighted sequences. Usually, as I said, it's asymptomatic, but can cause problems, especially if it's nearby neurovascular structures, as in this case, overlying the tarsal tunnel. Now, this could be a flexor digitorum accessorius longus muscle, or we can argue that it's a tibial-calcaneal internus muscle. I would have to show you the full stack of images. If it attaches, obviously, on the medial aspect of the calcaneus, just anterior to the Achilles, then we're dealing with a TCI. If it blends with the flexor dig, longus tendon, or inserts itself upon the quadratus plantae, then obviously we're dealing with the flexor digitorum accessorius longus muscle. Nevertheless, accessory muscle, know what it is, and it can cause some problems. Here we have an example on the right of an accessory soleus muscle, can have various attachments. A common attachment is upon the calcaneus superiorly, as we see here, the muscular attachment. But the important thing here, again, not to confuse it with a tumor. Again, it sort of has the same similar signal as the more posterior soleus muscle, okay? And this accessory soleus muscle. Interestingly, as patients get active, younger patients are active and they increase their physical activity. This can lead to a chronic compartment syndrome. So patients can present with pain sometimes. Sometimes, as I mentioned, can not only cause neurovascular or neurocompression, it can compress an accessory muscle can or anomalous muscle can compress upon a vessel. As in this case here, we have a third head of the gastrocnemius muscle overlying the popliteal vessels here. And this patient actually presented with claudication, and were able to confirm the dampened waveforms and decreased velocities with provocative maneuvers, thereby cinching this diagnosis of the third head of the gastrocnemius muscle, okay, causing these patients' symptoms with the claudication. Moving right along to that second category that I mentioned earlier, the edema and inflammation, and these two next categories, this is where we're going to be spending the bulk of our time. But increased signal on T2 or stir imaging, okay, the most common muscle pattern or abnormality that we see on MR, that indicates edema and or inflammation, as we know, okay. Cases of atraumatic muscle edema it is especially important to correlate with history. I'm gonna say that again. You need history, and as one of my mentors used to say, Eddie, you can't read muscle in a vacuum. Okay, you need that history. You need to take that time to read the patient's chart, go through the EMR, Epic, whatever system you use. But we can divide edema or that inflammation to symmetric and asymmetric patterns, helping us to cone down or distill that differential diagnosis. Symmetric edema, okay, is typically seen in inflammatory diseases, drug-related myopathies, whereas infection, radiation, myonecrosis, and compartment syndrome typically going to be more asymmetric and often focal, okay? You mix in some architectural distortion of the tissues. You can look for intramuscular fluid collections. Intramuscular edema can also be helpful and target what you're looking at, okay? So, but as important, MR, okay, is helpful for localizing active disease, the most affected muscle, okay, if anything. So, and that obviously we can subsequently target with ultrasound or perhaps sometimes CT guidance if you want to make sure you're at the right level. Idiopathic inflammatory myopathies, as in this case here, PET on the left, MR on the right, STIR or T2 weighted sequences, okay, are a group of autoimmune disorders that result in muscle weakness, inflammation, and it loves to involve the proximal extremity muscles, okay? These disorders, classically, depending on who you read, can be divided into 5 types, okay? There's dermatomyositis, polymyositis, juvenile myositis, myositis associated with cancer, okay? And then myositis associated with connective tissue disease, or CTD, if I slip into shorthand, okay? So poly and dermatomyositis are the most common and well-known forms. Both initially love to involve the proximal lower limb muscles, as in this case here, before affecting typically the buttocks, upper limbs, necks, and flexors, and sometimes the pharyngeal muscles, okay? In dermatomyositis, muscle and fascial calcifications may occur, but obviously hard and oftentimes dark on MR imaging. You're going to need radiographs or CT for that. That's going to be more conspicuous on those modalities. Up to about a quarter of patients, depending on who you read, with patients with poly or dermatomyositis either have or are later diagnosed, unfortunately, with malignancy. And interestingly, this happens about 1 to 2 years after the onset of myositis. Malignancies, for those that are interested, okay, that are associated with poly or dermatomyositis include lung, genitourinary, and GI cancers, and sometimes NHL or non-Hodgkin's lymphoma. Inflammatory myopathy can complicate autoimmune connective tissue disorders such as scleroderma, lupus, Sjogren's, rheumatoid arthritis, or mixed connective tissue disease, and overlap syndromes, okay? Muscle involvement is most common in scleroderma or in the overlap syndromes that include scleroderma and can affect anywhere from 5 to 95% of these patients, and this indicates a poor prognosis. Up to 20, a quarter of patients with rheumatoid or lupus can demonstrate myositis, muscle necrosis, or inflammation of various connective tissues. And an MRI, obviously, this case here with a connective tissue disease, indistinguishable pretty much, but to a lesser degree, obviously, from the previous case of poly or dermatomyositis. Moving right along, this a case, again, indistinguishable from poly or dermatomyositis. This turned out to be HIV-related myopathy. And this is thought to be seen in HIV patients, multiple factors, whether it's due to the virus, the drugs, or the host immune response to the virus. But if I told you this patient took statins recently, or perhaps a drug and got a drug-induced myopathy, could be that too. But drug myopathies, mind you, is typically a diagnosis of exclusion. But better yet, sometimes when you start or stop the drug and the imaging findings improve, or perhaps the muscle enzymes that our clinicians follow improves, that helps to support the diagnosis of a drug-induced myopathy. Okay. And importantly, sometimes it may be caused by an illicit drug. And remember, patients may not be readily forthright or disclose their apparent drug use. Okay, so sometimes we may have to do a little bit of digging and questioning. A bacterial infection called pyomyositis, okay, can infect the muscles through the bloodstream, adjacent infections, or damage nearby muscles, what have you, abscess, what have you, contiguity. Okay, it was once pyomyositis was once considered a disease of children and young adults, typically in tropical areas, but now these days we see it in immunocompromised patients. And unfortunately, as Americans, as we get bigger, larger, and sweeter, we see this quite often, especially here in the West Coast. Other risk factors may include drug use or weakened or immunocompromised, but also diabetics, as we know, can be considered immunocompromised patients. Pyomyositis most commonly is going to be caused by Staph aureus in about 90 to 95% of cases. But I want you obviously to remember your atypical and multi-organ infections, especially in immunocompromised patients. These infections love the lower extremities, particularly the thighs, gluteal, and psoas muscles. Pyomyositis, okay, continuing along this theme, is usually identified by large areas of non-enhancement, as we can see here in the soleus muscle proximally. Okay, this T2 weighted sequence obviously shows the pus, okay, within this abscess, but obviously that you may see sometimes intralesional gas as susceptibility artifact, or T1 and T2 foci, dark signal. And sometimes on T1, we MSK radiologists love to talk about the penumbra sign, which is basically a thin rim of increased T1 signal, okay, within these infectious lesions. Inflammation of the surrounding soft tissues can really help to differentiate abscess from a soft tissue tumor. And notice here, this robust sort of inflammation, particularly around involving or surrounding this abscess, but also some inflammation and likely infectious myositis involving the anterior and lateral compartment of the proximal lower leg in this patient. Inflammation, okay, in the adjacent soft tissues is really going to help us differentiate between an abscess and soft tissue tumor, as in this case, with an abscess, particularly involving the right psoas muscle, and obviously looking more centrally or midline, we see the spondylodiscitis involving this upper lumbar or thoracolumbar junction. Going along the lines of the theme of infection, here I give a nice mini case of cysticercosis, which is a parasitic infection caused by Tinea solium, common in developing countries, but typically it's caused by people eating undercooked pork. Okay, you can get it from contaminated water and vegetables as well, typically from fecal material from pigs or animals. Okay, and typically you're going to see this with accompanying neural involvement. People love to talk about the various forms of cysticercosis. It can present with myalgia, a solitary mass, multiple intramuscular cysts, but it typically has 4 stages. Okay, But the classic thing that we see in radiology is the last stage, that fourth stage, which is the calcific stage within the brain or within the on radiographs or CT. And what you see is rice grain, sort of like basmati or long grain rice, longitudinally oriented along muscle fibers. Okay, so this is just a nice case, I thought, of an MRR of cysticercosis involving the back muscles and also obviously the gluteal musculature. But notice how these T2 bright signal are longitudinally oriented along each muscle fiber. Okay, so cysticercosis. Moving along with edema, sometimes radiation, okay, can cause muscle edema, and that can lead to obviously radiation-induced myositis. This can also cause intramuscular septal edema, okay, related to radiation-induced vasculitis, and the signal change can persist for years, okay? Radiation-induced changes should be considered when you have a sharp band-like demarcation, and I dropped a line here between abnormal and normal signal, especially if you have an interface such as this within a single muscle, okay? And here you can see this tumor. I forget whether it was a MET or perhaps a chondrosarcoma involving the femoral shaft, but you can see that this patient was obviously radiated. And we also see the changes within the overlying subcutaneous soft tissues and fascia as well. And interestingly, you can have something that's called radiation recall. Okay, so you can have inflammatory changes after years after radiation, and say someone starts a chemotherapeutic agent, perhaps for a recurrent disease or a secondary um, cancer. Unfortunately, as we are able to keep patients alive longer with more comorbidities, you may see what's called radiation recall, where you get a reactivation of the previous radiation site from a secondary chemotherapeutic agent given to the patient. So, and if you think of that, that's something to think about. But again, you're looking for that sharp demarcation from the previous radiation field. Talk to your radiation oncologist, figure out where the radiation portal was, and that can help you, especially for patients, and avoid potential biopsy. Myonecrosis, where muscles get infarcted and liquefied, okay? Rhabdomyolysis is when myonecrosis is complicated by myoglobinemia. And this obviously can lead to subsequent DIC, or disseminated intravascular coagulation, acute renal failure, and ultimately, or sometimes unfortunately, death, okay? Causes or risk factors for these are trauma. Someone lays on the ground for too long. If they overdose, unfortunately, as we know, we have an opioid crisis, so we see a lot of fentanyl overdose here in the West Coast. So people will sometimes come with rhabdo because of that. They'll present, sometimes diabetics are at risk, compartment syndrome, overdoing it, exercising way too much, heat stroke. Radiation can also cause it, metabolic disorders, envenomation, toxins, and illicit drug use, okay? But when you're dealing with myonecrosis, the literature talks about two forms. Type 1, as we see here, demonstrates non-specific homogeneous edema and enhancement, as we see here. Again, you really can't discern this from polymyositis or the HIV myopathy that I showed you. You need to comb through the chart. You need that history, okay? Very difficult to parse that out. The type 2 of myonecrosis, the so-called stipple sign, here we see inhomogeneity with foci of low signal intensity demarcated by areas of non-enhancement involving the gluteal musculature, and the viable part is, or the enhancing part is thought to reflect the viable muscle and in the inflammatory vessels. But remember, be careful giving contrast to these patients, because they may already have renal failure, so you don't want to box the kidneys in even further. And renal failure is typically seen in anywhere from 10 to 25% of patients that would come in with myonecrosis. Acute compartment syndrome, again, if just given a T2, could be myopathy, could be inflammatory myopathy. But this, as we can see here, this is infected leg. And this is a case given to me by my mentor, Minnie Pathria. This infection by Pseudomonas actually led to an acute compartment syndrome, and we can see here this non-enhancement not only within the anterior compartment but the deep posterior compartment of the lower leg here. Acute compartment syndrome typically affects the lower legs, but it can also occur in the forearms, thighs, and paraspinal muscles. It's typically a clinical diagnosis confirmed by intracompartmental pressure measurements, and my orthopedist tells me they tell me they worry at about 65 or 75 millimeters mercury or more. And this obviously requires immediate surgical decompression to prevent myonecrosis and potential bad things, compartment syndrome, death, what have you. Imaging is not the primary tool for diagnosis, but if you happen to image it, this is what's going to look like. What you're going to be listening for are those 4 or 5 P's, if you remember from medical school, right? So you're going to listen for pain, paresthesia, pallor, pulselessness, and I probably forget another P, but we could probably make one up, okay? But these, when present, prompt immediate surgical intervention. So this is a case of acute compartment syndrome. When it happens chronically, okay, this can result in atrophy, fibrosis, or as in this case, calcification. Patient came in this case, pretty normal, just some non-specific soft tissue swelling laterally. We got the MRI. We can see ultimately this led to calcific myonecrosis. This an Aunt Minnie, or what I like to also call an Uncle Mickey or Aunt Minnie, but usually it's going to involve the anterior compartment of the lower leg. It loves to involve this part of the body, and typically what you're going to see if this happens after trauma, so you're going to be looking for an associated, typically a fibular fracture, a heel fibular fracture, or tibial fracture. Okay, so calcific myonecrosis. This does not need biopsy. Okay, but if you're potentially biopsy, be careful. Please consent the patient for potential superimposed infection, because as we know, a hematoma is just a blood culture waiting to be infected. Okay, so something to think about. Diabetic myonecrosis or rhabdomyolysis, an uncommon complication of type 1 or 2 poorly controlled diabetes. These patients will present with severe pain, okay, swelling, typically, and loves to involve the anterior thigh or quadriceps muscles. Fever, unfortunately, can happen depending on who you read in about 10-15% of patients, making it difficult to differentiate from pyomyositis and abscess that I showed you earlier, okay? Can be multifocal, bilateral, and you're going to see the signal alteration in muscle compartments in diabetic patients in about to 50% of patients, okay? Here, this is basically dead or ischemic muscle, infected muscle, right? And or sometimes super infected muscle, sorry, but this is what you're looking for with the surrounding inflammatory change on these post-contrast images, okay? And again, as I mentioned, difficult to differentiate from pyomyositis, and sometimes they'll have that white count or fever, non-specific. If you're asked to biopsy this, you may have to under ultrasound or CT just to prove it. Moving along to our third group or category of muscle diseases, the masses, okay? And the presence of a mass in the body can indicate a whole variety of conditions, as we know. Can be a neoplasm, could be a pseudo-tumor, could be metastatic disease, could be a non-neoplastic neoplasm or a pseudo-tumor, as I mentioned. And such the diagnosis depends on a number of factors, right? Including age, medical history, and perhaps sometimes other imaging results. But again, we need history, okay? You need to comb through that chart. And some cases, though, and I'll show some of these here, MRI and imaging can provide us with a specific diagnosis. Here, a nice case of what used to be called a hemangioma. I encourage us to use vascular malformation as our terminology, but what we see here is this large mass at the ulnar aspect of the elbow that has septae and fat insinuation within it. Corresponding radiograph, cone down and cropped, obviously showing the sub-centimeter phlebolis, diagnostic of a low-flow vascular malformation, or what some people may call a hemangioma, just so you're aware. Most common benign tumors that develop within muscle are going to be lipomas, hemangiomas, as I provide here, myxomas, and fibromatosis. Speaking of myxomas, here we have one in the rectus femoris, and we see the stranding or that leakage of fluid on either the cranial and caudal end of this lesion, but you don't want to dismiss this as a cyst, okay, or soft tissue ganglia. Number one, it's too deep. Number two, it's not communicating with the nearby joint. Okay, so you gotta give this contrast. Okay, and make sure you're not dealing with a mucinous neoplasm. Worst case, a mucinous liposarcoma or myxoid liposarcoma. That's the worst case, right? Myxomas in this case, right, can be non-enhancing, could be partially enhancing, but more often in the literature and anecdotally in my experience, it's sort of heterogeneously enhancing. Loves to involve the thighs of adult females. And one thing to think about is the association with Maza-Brod syndrome. Okay, so think about that. Liposarcomas, which this case wasn't, neoplasms of fibrous origin, which this isn't, and lymphomas are typically the most common primary malignancies to involve muscle tissue. But this case, as I show here with the fiduciary markers, turns out to be a rhabdomyosarcoma. Uncommon type of cancer involves the skeletal muscles and their precursors, okay? And in most cases, unfortunately, this can occur in children at extramuscular sites, particularly the head, neck, and GU tract, as we know. But this case involved the forearm in this kiddo. MRI is great in detecting muscle lymphoma, as I mentioned, but typically with lymphoma, unlike this case, which turned out to be a muscle metastasis, lymphoma is typically be infiltrative, go along the muscle fibers and fascicles, and it shows relative preservation of the intramuscular fat planes. Muscle mets typically going to be rare but globular. Okay, when they do, I want you to think of lung cancer, melanoma, and other primary malignancies involving the GI and GU system, such as renal cell carcinoma. Those are the ones that love to involve muscle mets, as in this case, involving the right erector spinal muscle. I think this was an RCC, and you can see here it's quite hypervascular with a flow void or a couple of flow voids in here indicating or supporting the diagnosis of an RCC. Hematomas can occur from trauma or anticoagulation therapy. Again, comb through the chart, look for the INR, coag profile, see if it's elevated or out of whack. Can present with a commonly in the psoas muscle, as we know, but the other location, as we know, is the rectus abdominis muscle. MR imaging appearance can vary depending on the stage or of the blood products and degradation products. If there's no clear history, though, please, you gotta follow this sometimes, right? Because you want to make sure that you're not dealing with perhaps a mesenchymal tumor that's bled into itself, right? Especially, say we're dealing with a hematoma within the thigh muscle or an arm, and hey doc, I just bumped myself, now I have this lesion, I feel it. You want to follow that at least clinically or perhaps even by ultrasound. Make sure it clears up. Make sure you're not dealing with a rare hemorrhagic or a neoplasm that's hemorrhaged into itself and you're just happening to picking it up now. Focal, rare case, nodular myositis, a rare inflammatory pseudo-tumor of the skeletal muscle, typically rapidly enlarging and very painful. Okay, here involving the medial aspect of the soleus muscle. Again, non-specific, no way to know. Okay, and you may have to biopsy it. Okay, and it may to establish the diagnosis here. But this was a proven case of focal nodular myositis. Rare case, love this case. This was a case of sarcoid. Okay, a disease, as we know, non-caseating granulomatous process in muscle can present as two types, diffuse or nodular, nodular as in this case. When you're dealing with the diffuse type, it'll just look diffuse, and a gallium-67 study may help you to diagnose it in that case. But in the nodular type, it's typically more obviously nodular, distinct, and can be seen in about, 1 to 5% at most of patients with sarcoid. When we do see it, unfortunately, when sarcoid involves the MSK, musculoskeletal system, this portends a poor prognosis, okay? Loves to involve myotendinous junction, okay? In the axial plane, you'll see this sort of spiculated appearance, giving what's called the dark star sign. And then if you image it in the longitudinal axis, you'll see the stripe sign, or what's been called the three stripe sign, 1, 2, 3. So this is a nice case or proven case of sarcoidosis. If you think of it, you want to think of the concomitant, often seen pulmonary nod or pulmonary symptoms. Maybe you want to get a chest radiograph at the least, or perhaps even look for a CT of the chest, look for the hilar adenopathy, or sometimes the multiple pulmonary nodules, typically within that lymphangitic spread and what have you. But as we know, sarcoid loves, can do anything. And for those perhaps taking a future test in the near future, I want you to remember the memory tool, SALT, MSALT, melanoma, sarcoid, amyloid, lymphoma, TB. These are these multi-system processes that can involve multiple locations. So if you don't know what you're looking at and it involves multiple organ systems, think of salt. Okay, and as we know, salt is the seasoning of life. Okay, fibrosis here, as we can see, calcified partially, dark on our T1 or T2 weighted sequence. I apologize, I forget. And here confirming that calcification. Fibrosis or deltoid contracture, as in this case, can be caused by intramuscular vaccinations. Classically or historically described with flu vaccines or meperidine vaccinations, can result in these cord-like structures, and it's actually a well-documented phenomenon. Can lead to muscle atrophy, skin dimpling, fibrosis, and as in this case, in the bottom right of the radiograph, we see this scapular winging. So keep that on the differential for scapular winging, not just involvement of the long thoracic nerve with injury to the serratus anterior muscle or atrophy there. MRI, as we can see here, okay, it looks dark, like fibrous tissue, collagen. You know that this is collagen rich if it's dark on T1 and T2 weighted sequences. Here, people, vanity, one of the many sins or 7 sins, okay? We like to look good. We will sometimes inject things in our buttocks, breasts, dorsum of the hand, cheekbones, calf to keep looking good, okay? And in this case, as we see here, I like to call this the so-called starry sky appearance, but this patient injected either fat, hyaluronic acid, silicone, and sometimes you can have even silicone implants, right? But this a case of iatrogenic injections. They probably went to, since we live in San Diego, oftentimes our patients will go to Tijuana or across the border. I used to practice in New York and Connecticut. We used to call this back in the East Coast, what's called the Bronx Special. But patients will come in with that, rule out abscess, rule out mass, but then you just ask them, hey, and again, patients may not be forthright, and if they're not, you can ask them or potentially ask your clinician to do a breast exam, because oftentimes they'll do this to their breast as well. So something to think about with these iatrogenic injections. In this case of silicone or fat or hyaluronic injections, causing this so-called starry sky appearance. Sometimes we can have, and this sort of overlaps with edema and masses, okay? But we have here this robust edema, particularly involving the infraspinatus muscle, its superficial aspect, and to a lesser extent, the superior aspect of the supraspinatus muscle. But this is a case of calcium hydroxyapatite, or what we used to call here at UCSD calcium hydroxyapatite, or HAD. We are trying to use the name basic calcium phosphate deposition now because recent literature highlights the fact that there are 3 forms of calcium: calcium hydroxyapatite or carbonate hydroxyapatite, aka duraapatite, and you can check with Dr. Google. That's the first form of calcium, the most common form of calcium, okay? And that's the most common form of calcium that deposits within soft tissues, and it's also a major constituent of bone. The other 2 forms, it's, and you could correct me if I'm wrong, it's tricalcium phosphate and octacalcium phosphate. But all 3 forms of these calcium can apparently cause calcific tendinosis, okay, or calcific periarthritis, or whatever terms you use. Whatever terms you use, though, I highly recommend that you communicate, keep that open dialogue with your clinician so that we are all on the same page. But this, as you can see, was a case of basic calcium phosphate tracking within the supraspinatus, okay, and more so the infraspinatus muscle, causing a robust myositis. And this actually patient came in for rule out either trauma or infection, which is the typical case for these cases of basic calcium phosphate with muscle extension. Okay, and sometimes, as we know, this can also track into the bone and cause a robust edema, in which case it may be misdiagnosed as a tumor or perhaps osteomyelitis. What helps us, obviously, is radiographs or CT displaying that calcium. Okay, so this just a nice case of basic calcium phosphate with muscular extension. Okay, so something to think about. Talking about sliding right in, and I think we're pretty decent, hopefully on time, about the atrophy portion or the atrophic of the last group, okay, of muscle disorders. But before we talk about atrophy, need to overlap a little bit. And as I mentioned earlier, there's a lot of overlap. But let's talk real quickly about subacute and acute edema or denervation, as in this case, we see here edema involving the supraspinatus and to a lesser extent the infraspinatus muscle. This a case of denervation myopathy caused likely by dinging of the suprascapular nerve, which is a nerve root of C5 and C6. Maybe it's from the cervical spine, a labral cyst. I forget. I apologize. But this is a nice case of denervation atrophy involving that nerve root distribution. Acute denervation, okay, the muscle signal intensity changes can be visible in about 4 or 5 days, depending on who you read. Subacute, I like to call that when you still see this edema, but then you start to get wisps of atrophy or fatty replacement of the involved muscles. Here, another case of denervation edema, a paralabral cyst, dinging or extending into the spinal glenoid notch, dinging the more distal part of the same nerve that we just previously talked about, causing preferential edema of the infraspinatus tendon. Or how about this case? We see this axillary nerve, bright, okay, from axillary neuropathy or neuritis, causing a denervation edema of the posterior portion of the deltoid muscle and the teres minor muscle, confirming or supporting an axillary neuropathy. Or how about this case? Let's look more distally. Soft tissue ganglia or synovial cyst along the anterior aspect of the the fibular neck or proximal shaft, likely dinging the common perineal nerve and its branches, as we can see here with the edema involving that anterior compartment of the proximal lower leg in this case. And finally, chronic denervation. Anything can look like this. If you wait long enough, whether it's denervation edema, an inflammatory myopathy, what have you, you wait long enough. Sarcopenia, right? You wait long enough. We're all going to end up like this, unfortunately, where muscle is irreversibly damaged, atrophied, and I believe this case was a case of polio. Unfortunately, we have a lot of migrants, and we still see a lot of post polio syndrome. So this was a case of that. But as we can see here, there's just basically no fat or no muscle bulk, particularly involving the image portion of the proximal thigh muscles. But if you wait long enough, any of these processes involving the muscle can eventually lead to this. Probably not so much masses, but obviously if you radiate a muscle mass and you wait long enough, in theory, it could lead to this sort of robust fatty atrophy. So to summarize, 4 main patterns of muscle conditions. Preferentially, we should use MRI. We think of abnormal anatomy with normal muscle signal, as in the far left here. And I think this is being recorded. I'm happy to share this as a PDF as well. The second, edema and inflammation. And again, we can divide that into symmetric or asymmetric diseases. The masses category, and again, that could be neoplastic or even our pseudo-tumors. And then the end stage, or maybe subacute or chronic. And here, as I mentioned, sarcopenia or foregone myopathies lead to atrophy. Okay. So, but as I want to harp right on you guys, please, please, please don't forget clinical information, as a lot of these diseases can cause overlap. It's a spectrum in its presentation, depending on when we catch it. MRI helps us to plan biopsy and obviously can help to guide appropriate management. Remember to think of our anatomic muscle variants, accessory anomalous muscles, anomalous courses that can be easily overlooked, especially because they blend with the remaining muscle. Muscle edema, common pattern, non-specific. We need that chart. The differential is broad as I share here. Can be autoimmune, paraneoplastic. We talked a little bit about drug, infection, radiation, myonecrosis. Look for that architectural distortion. That can help. We talked about intramuscular masses, primary neoplasms, metastasis, several benign, low-grade hemangiomas or low-flow vascular malformations, things like that, and other things like basic calcium phosphate that can simulate malignancies. And then finally, atrophy, okay? Typically the irreversible end result of any muscle disease, okay, of sufficient severity, and that can dominate disorders such as, disorders such as muscular dystrophy, late denervation myopathy, as I showed, and sarcopenia, as I mentioned earlier. So we can really help people. Try MRs, look at your muscles, comb the chart. So with that, I provide a few questions, and please feel free answer on the chat. So the first question and take home point, true or false, muscle diseases are distinct and easily diagnosed by imaging. So this, obviously, I'll pause for a moment if anyone wants to respond on the chat. False, yeah. Thank you, Dr. Davis. Dr. Lawrence, false. So we need history, right? So as I was saying, there's a lot of overlap. You need to correlate with history, clinical information, laboratory findings, other modalities, and occasionally tissue sampling. Next, hopefully, next question. Okay, true or false? History and context are unimportant in radiology, especially in the workup of muscle diseases. Obviously, false, and kind of ties back to the previous slide. Okay. And last question. We should be most concerned when presented with muscle that is A, anomalous, B, edematous or contains a mass, or C, atrophied. And I'll pause for a moment. B, thank you. Thank you, Dr. Acevedo and others. Yeah, so when it's edematous or mass, when it's anomalous, obviously you don't need to biopsy that. Just give the patient a hug, tell the clinician it's okay. We can follow it at the most. Atrophy, things are typically far gone by then. So here are some of my references, and I just like to highlight a recent article by a group in Brazil that published on atraumatic muscular disorders. Check that out. But we also published on this a few years back, and that was in Radiographics, I think, 4 or 5 years ago, but it's referenced here. I'd like to take a quick moment just to acknowledge my teacher, mentor, and now colleague, Dr. Pathria, who pushes me every day and helped me organize and help write this paper and create this talk. And obviously my UCSD MSK family could not do a lot of the things that we do without them. So thank you. You all know who you are. I'd also like to give a shout out to Dr. Flores and Dr. Catalina Gomez, who were also on our article that we put out on atraumatic muscle disorders and provided some of these images and schematics. And I also like to take a quick moment, reach out. As Dr. Smith said, I used to be at Yale. I'd like to thank Dr. Hames, Mukadam, and Dr. Katz, if they're out there, for turning me on to bone radiology. And so thank you so much for the committee for having me, and hopefully we feel a little bit better and a little bit more willing to deal with some muscle disorders. And with that, here's my IG QR. That's my email for any questions, comments, concerns, or complaints, and happy to stay on for a little bit for any questions or concerns.
Great.
Thank you so much, everyone.
Thank you, Dr. Smitaman. That was fantastic. Wonderful talk and really covered the gamut of muscle abnormalities and beautiful images and drawings. So thank you. We do have a question in the chat. And the question is, do you have any experience using DWI for identifying muscle infection?
Yeah. We do we do DWIs on pretty much everyone, especially for tumors and pseudo-tumors. But in all honesty, it's not like brain imaging. So even though if it sort of acts like a duck or quacks like a duck, and they're still worried about infection, and the DWI does not correspond, we'll still get asked to biopsy, and I'm happy to go after it. Typically after under ultrasound or MR, and I'll take a preemptive step here. The next question will probably be, what about your tumor imaging? Yeah, we do that too, but again, anecdotally, I've noticed that depending on the tumor histology, you don't always see that restricted diffusion. You typically see it, yes, when something, let's say, is a small round blue cell tumor, something that's packed in together, not a lot of space for that Brownian motion, and in which case you're going to expect the ADC values to be less than 1, but it doesn't always help. So and quite frankly, I think it's histologically dependent. So still, we're still biopsying things, but hopefully we'll get there one day.
And there's one other question in the comment. How do you tell the difference between reactive edema in muscle in a patient with cellulitis versus true pyobiocytis?
Contrast sometimes, but again, it can be helpful, but I've been burned both ways before. I would have to look at the latest literature on that, but perhaps contrast. But again, we're fortunate to work very closely with our infectious disease colleagues, and we take care of an indigenous population, and sometimes when the first admission where we get our patients is the first and only time we're going to see them, so they'll get a thorough workup, including sometimes biopsy for potential infection, and we'll send that off. So I'm probably more aggressive in that sense, because knowing that full well that this may be the only time we get the patient on the appropriate antibiotic. So but contrast may help.
Fantastic. Well, thank you again. I will remind everyone that there will be a survey that's going to be dropped. In fact, it's right there now from Patrick. And if you can fill it out and give us feedback on the webinars, these have been highly successful, and it's a great way to learn from each other and meet one another, even though we're across the country or elsewhere. With that, I'd like to thank the audience. I'd like to thank the SSR for putting this together. Again, thank Dr. Smitaman for the time and effort and teaching. Thank you. Our next lecture will be on June 12th. It will be at 7 p.m. and it will be interesting spine cases presented by Dr. John Szymanski. With that, have a wonderful evening, everyone.
Thank you, everyone. Be well.